Wonderful. So the kind of basis for these was, it sounds like you guys really didn't have much in your didactics covering these topics, and I tailored them more towards making sure we hit all the same things that were hit in the MICSAP questions. The good news was that looking over the 2016 MICSAP questions was that the questions about bipolar disorder, about anxiety, about somatic complaints were pretty straightforward. So not a whole lot of things to worry about, just basically being able to recognize the difference. And so we'll kind of go through those. If you guys have questions, feel free to interrupt me at any time, not a problem. Pretty often in medicine, we get upset or frustrated when we have to deal with something that we don't necessarily see as within our realm of practice. And it's for psychiatric issues, you kind of hear it all the time, like, oh gosh, another psych patient, or this person's just complaining, or any number of things that that we'll use kind of, hopefully not in front of the patient, but sometimes on treatment teams or in rounds or in the in the cafeteria. But despite not wanting to call ourselves psychiatrists, this is a graph from a CDC survey. On the x-axis down there, we have ages, and on the y-axis, percentage. So this is the number of kind of mental health-related primary care visits. Overall, it's about 20%. If you get above 75, it's greater than 30%. And it's, if you cut out the underage and the 12 to 17 age bracket, it winds up being a little bit higher than 20. So these include, visits to the primary care. This is all outpatient, where the internal medicine, the family medicine doctor, they're prescribing psychiatric medicines, dealing with a psychiatric chief complaint, performing counseling, so that's like smoking cessation counseling, or even psychotherapy. So, whether you like it or not, this is part of your practice, and treating patients with psychiatric illness is part of your practice. What we know about internal medicine and about psychiatric patients is that more often than not, they'll go to the internal medicine doctor or the family doctor before they'll go to the psychiatrist. So a lot of times you'll be the person that they're interacting with because of stigma, because of fear, because there's not one in town. You're going to be the person that's going to be prescribing these things. So it's not, this stuff isn't rocket science, but it's important to kind of come armed, being able to ask the right questions and being able to recognize when you feel uncomfortable and when you don't, feel like you're doing the right thing. So quickly, we'll kind of go through the diagnostic criteria. Now, this is pretty straightforward. So how you diagnose bipolar disorder is by manic episodes. I'm sure that most of you guys, whether on the wards or whether, doing a consult up on 5 East, you've probably seen a manic patient. They're pretty easy to pick out. They're usually the one that's super intrusive, coming up into you, asking you lots of questions, talking really fast, telling how they need to get out of here because they have the cure for AIDS. So those manic patients are really easy to diagnose because, they look really manic, and, it's a simple diagnosis. What becomes more complicated is that most of the time when they present, they're not going to present as manic. There was a kind of study following patients with bipolar disorder in the outpatient clinic, and what they found was that at follow-up, 30 to 35% of the time they presented as depressed. About 10% of the time they presented as mixed, so this is having some irritability, maybe being a little keyed up, but also depressed. And then only about 5 to 8% did they present as frankly manic. So more often than not, the patients that you see with bipolar disorder in your clinic are going to be depressed and are going to tell you about feeling depressed. So how you diagnose bipolar disorder is with mania. The big things that you have to kind of key into are this decreased need for sleep. That's usually when I'm taking a history on a patient and asking about depression and asking about mania symptoms. How I'll lead will be with, tell me about a time in your life where you have experienced a period of several days or a week where you just didn't feel like you need to sleep as much. where maybe you were going on 2-3 hours a night, but you felt rested, you felt like you had energy. Because sometimes when you phrase mania as just being like, hey, tell me about a time where maybe you were spending lots of money, using lots of drugs, doing crazy things, more often than not, like, people are not going to have those experiences, because we see that in the hospital, but there are lots of folks with bipolar disorder that don't get hospitalized, that don't do all sorts of really crazy things, but that still have bipolar disorder. So I'll usually start with this decreased need for sleep, and then kind of segue if they have a clear history of that or something suggestive of that. And then I'll ask them more about, were you doing things that were out of character for you, maybe starting new projects and weren't finishing them? If you're single, maybe were you going out and meeting lots of people? So you have to kind of tailor it to what the person, is like. I know one of my mentors here has he always talks about, bipolar disorder presents differently in different patient populations. And we have really good data about the Amish because it's a controlled community. And sometimes mania in Amish is, the guy stole the horse from the barn and rode around the town in the middle of the night, which, doesn't sound that crazy, but in the realm of, in the cultural context, it's a big deal and it's out of character. So you also have to think about kind of the culture that the patient's coming from. Yeah.
Can I tell you a similar story that one of my neighbors, kind of all the other neighbors diagnosed her as having a manic episode because she was up all night posting kind of grandiose things on Facebook, literally every 1 minute.
Yeah.
There was a new post from her all night. And so, anyway, she definitely didn't need sleep.
Yes. Yeah, no, and it's, if a patient, a lot of times in EPS, someone will come in and collateral or family will say that they were putting weird things on Facebook. So I'm always really excited when the person doesn't lock their Facebook account, because looking up, kind of personal social media stuff a lot of times is really helpful. But I've had similar patients who, they swore they were not. I have, thinking one patient in particular who swore that she was doing really well and that this was normal and that she did deal with some depression and some alcohol use, but that she didn't have bipolar disorder. Her social media account was not locked, so I was able to type in her name and pull it up, and she had this image of her writing. It was posted at 3 a.m, and it was her writing. She's saying that she was working on writing this novel, and it was a desk, a picture of her desk, and it was just completely covered with papers all over the place, and it was okay. So I'm glad that that I have some seeing this in another setting. So apart from this, increased goal-directed activity, a lot of times what you see it as is just more irritability. So if someone doesn't present euphoric, it's not to say that they don't have bipolar disorder. What you'll see a lot of times is just someone who's usually, fairly low-key, maybe really nice to people, has a period for 1 or 2 weeks where they're not sleeping well and are just really mean, really irritable, kind of pacing, not able to sit still at work. That is also that's also mania. It doesn't look the same. It's not as bad as the person you see hospitalized, but it's important because this will help steer treatment. So it's not expected that primary care physicians will be treating bipolar disorder. But it is important that, you guys are kind of recognizing when you have a suspicion that someone might be bipolar and helping either, direct them to psychiatry, maybe have them come down to EPS for an evaluation, maybe talk about seeing, a therapist or a psychologist who could help with the diagnosis. Now the latest screening from the U.S. Preventive Services Task Force recommend that we screen all patients, all general adult patients, for depression. So if you're going to screen everybody for depression, you really also have to screen folks for bipolar disorder. And like I said earlier, it usually shows up as depression. You're not going to see too many kind of frank manic patients in your clinic, because usually if they're manic, they feel pretty good and they don't want to come to the doctor. And you've got to coordinate care. And then also, a lot of the medicines we use for bipolar disorder and for other psychiatric illnesses carry a lot of medical side effects. So whether it's, problems with your kidney with lithium, using antipsychotics that induce metabolic syndrome, or using mood stabilizers that screw with the metabolism of just about everything else. You have to be really careful. So it's important kind of following up with the medical problems that psychiatric patients have, because they're much more likely to have cardiovascular disease, obesity, and they're going to be just at greater risk for having medical comorbidities. So this little graph, I think, is kind of helpful, because a patient that has bipolar disorder, like we talked about, can look really different when they show up in your clinic. So, this manic mood behavior, that one's pretty easy to see. If someone shows up in your clinic, you kind of know what's going on. The psychotic one, you might think like, gosh, this person maybe has schizophrenia or has a psychotic illness, and it could turn out that they are depressed and have psychotic features, or also bipolar disorder with psychotic features. So what you wind up seeing is more people on this right side of the graph with the depression, the anxiety, more irritability, or maybe they come saying like, I can't focus at work, I'm really distracted. So if somebody shows up thinking, with the chief complaint of being anxious, you're thinking more like, okay, I'm treating this guy for anxiety. Or if they show up saying, I've been really depressed, maybe you're not thinking about bipolar disorder. Or, if they show up saying, I can't focus at work, you're thinking, okay, maybe I'll start this person on a stimulant. But these can all be symptoms of bipolar disorder. And it makes diagnosis tough, and it makes treatment hard, because what ultimately happens is that, the can kind of gets kicked down the road until the diagnosis gets picked up correctly. One of the things that's interesting here is that 100% of patients with bipolar I disorder over their lifetime will experience another psychiatric illness. So maybe they'll be coming to you complaining or describing wanting help with their anxiety, but they have this underlying bipolar disorder. And it's 95.5% of patients with bipolar disorder over their lifetime will experience 3 or more other psychiatric illnesses. So these folks with bipolar disorder have a high comorbidity with other psychiatric illnesses, as well as medical problems. You have the thyroid problems, more likely to have somatic complaints, migraines, headaches, COPD. These folks are more likely to smoke, and then of course obesity, diabetes, and cardiovascular disease. So we'll just kind of walk through a case. This is a 27-year-old guy, comes to your clinic. He reports several months of feeling depressed. He's having a hard time concentrating, not enjoying what he does, his hobbies. He's gaining weight, sleeping poorly. He feels like things aren't going to get better, but he doesn't have any suicidal thoughts. But sometimes he'll be thinking about what it's like to be dead, or just having these kind of intrusive thoughts of death. He's had several of these in the past. So what's our next step going to be? And I guess we could do a show of hands. Who wants to start him on Celexa? And what about Remeron? And then what about obtain more history? Yeah. And then the other thing is just observe or refer to psychiatry. I'm surprised that maybe some 10. Yeah. Okay. So, of course. And this is pretty similar to the MICSAP questions that were about bipolar disorder. This is 2016 MICSAP. So that you have a patient that presents with depression, and what you really want to make sure is that before you diagnose major depression and start treatment for depression, you really want to make sure that there's not anything suggestive of bipolar disorder. So you guys keyed into that correctly. So you ask him about, what antidepressants have helped in the past. And he reports that things haven't really helped, that he got more irritable with citalopram and sertraline. Those are both SSRIs. So you ask, maybe he's got bipolar disorder. I'll ask about mood swings. And he says, no, he's a pretty, level-headed guy. So, and the reason that I talk about mood swings is that, you'll hear your patients say, like, I've got mood swings, I have bipolar disorder. And mood swings are not the same as bipolar disorder. I'm sure that you guys all know that, but when you're asking about, trying to elicit symptoms, it's important to ask the questions in a way that you actually get the information you're looking for. Because if you just ask about mood swings when you're really meaning manic symptoms, even though you kind of know what you're getting at, it might lead you down the wrong course. So then you go into this next question asking about, decreased need for sleep, and he says yes. And he also says that during these phases, he likes it, he gets a lot of work done, but he did have some problems. He got a DUI, and one time started a home renovation. So, this is not the mania like we said. This is not the mania that you see in the hospital, but this history is pretty suggestive of someone with bipolar disorder. And then the last key part there is asking about family history. And so he reported that his grandmother had a psychiatric problems and was hospitalized, but he doesn't know specifics. So when you ask about family history, what I've found is that a lot of times people will either not know their family's history or say that he's a bipolar schizophrenic or like some kind of psychiatric term that doesn't exist, or just say they're crazy. So it's really hard to take your patient at your word for what their family members have. But if they give a family history that's suggestive of depression, or maybe a family member who had substance problems, or a family member that had some sort of psychiatric burden, that should be a clue that, geez, maybe I should be a bit more sensitive to this person potentially having bipolar disorder. So we've got some more information. We are pretty sure that this guy has bipolar disorder. What are we going to start with? What do we want to pick? Anybody except Dr. Campbell? Someone walk me through like their what they're thinking.
Lamotrigine.
Okay. So how did you arrive at lamotrigine?
So assuming he has bipolar, you want to start him on a mood stabilizing agent. Mm-hmm. Which is something that's antidepressant, there's a chance that
yeah. Good.
Lamotrigine is
Yeah, and what did you think about gabapentin or lorazepam?
I've never seen gabapentin used for sexual illness. I guess psychiatry related issues.
Yeah, so gabapentin, often it gets used for anxiety. It is not a mood stabilizer that's effective. There's some idea that maybe at really, really high doses it could be an effective mood stabilizer, but for the doses that we use with our patients, it's not an effective mood stabilizer. And I threw in that benzo just to make sure that you guys know not to prescribe benzos to patients. And with paroxetine and sertraline, with someone with a history that's suggestive of bipolar, you really want to shy away from starting monotherapy with an SSRI. Antidepressant monotherapy is not indicated for bipolar depression. It's not first-line treatment. What you wind up seeing, maybe talk about this on the next slide, yeah. So kind of the thing to take away is that you really don't want to prescribe antidepressants for a bipolar depressed patient. Your first-line treatment is going to be either an atypical antipsychotic or a mood stabilizer. And in the mix-app questions, they didn't give you the option of picking, they didn't have antidepressants, atypical, and mood stabilizer. They made it pretty straightforward. They were either, a mood stabilizer and then a bunch of antidepressants. So I wouldn't expect that the level of knowledge that you guys would have, we have to pick between lamotrigine and Seroquel. But just know that you really should be staying away from monotherapy with antidepressants. Any questions about that?
Hey, Zach.
Yeah.
Have you ever read the package insert for lamotrigine? It scares the crap out of you.
Yeah.
Your skin falling off.
Yeah.
And have you ever seen that?
I've had one patient. It was actually the first patient I ever started on lamotrigine that developed Stephen-Johnson syndrome 2 weeks before her wedding. So I felt horrible. And we kind of picked it because it was the safest. And actually I'll talk about her a little bit later. So, that answer choice is actually one of the mix-app questions. I would never expect, I don't think insurance companies or other physicians or psychiatrists, I would never expect a primary care doctor to feel comfortable, starting lamotrigine without, maybe if they were in a rural community and they needed to talk to a psychiatrist and we could coordinate. It's not as big and bad as scary as it sounds. You just go really slowly on the titration, and you alert the person that, hey, you be aware of these symptoms of developing this rash. If you have it, stop it immediately. Call me. Come to the office. I have a couple patients that are on lamotrigine, and they have my phone number. And so I've had one who was concerned about a rash, and they just, they didn't know they go to the emergency room, so I just had them text me a photo of their rash, and it was just like contact dermatitis, and they were fine. But it's important, that when you do start a patient on lamotrigine, that you really got to make sure that they're going to be taking the medication every day as prescribed. They're not going to be missing doses, because that's, Stevens-Johnson syndrome is the thing that you worry the most about it.
If they come in on lamotrigine, what should we do as far as being cautious about starting or stopping it or other medicines?
Yeah, so, you want to make sure, I think if you've missed it for 5 half-lives, you have to start over from scratch. So these are patients that, if they are coming on lamotrigine and they're going to stay on it, I'll always make sure they have like a ton of refills. Because, I don't know, on the primary psychiatry side, our patients miss visits, and that happens. And so I don't want them to miss a visit and then to go off their lamotrigine and then have to restart it, because it takes weeks to get back up to a high dose. The good thing about using lamotrigine for bipolar depression is that you wind up seeing some efficacy, about 50 milligrams. So, you do 25 milligrams for 2 weeks, you go up to 50 milligrams split for 2 weeks. So you don't have to go up to the crazy high doses that take, weeks or a couple months to get up to.
Remember that valproic acid will double the levels of lamotrigine. And the one case with Stevens-Johnson was in someone who had Depakote added, not for mood stabilization, but it was for seizures, and they were already on Lamictal, and they developed because the levels go.
Yeah.
The other thing is, if you write for lamotrigine, make sure you spell it correctly.
Did I spell it wrong? Jeez. There we go. This is why I invited him. And then also carbamazepine will reduce the level. So if someone is also on carbamazepine, that'll reduce the level of lamotrigine. So if suddenly they get worse, because their neurologist or whatever reason that carbamazepine got added, you might have to also think about going up on the dose. So, these other things are also lithium, atypical antipsychotics can be used for bipolar depression. I guess one final thing, so there's this Embolden 2 study. So this was a study that had looked at patients with bipolar depression and started them on either paroxetine, Paxil, Seroquel 300 milligrams, or Seroquel 600 milligrams. And what they saw was that the patients that were on monotherapy with Seroquel had an improvement in their depressive symptoms. The patients who were on Paxil were no different than placebo. And there was no dose effect with Seroquel. So 300 milligrams wound up doing just as well as 600. There's another big study, the STEP-BD study, and this looked at treatment of bipolar depression and using a mood stabilizer in addition to an antidepressant. So there's this idea that if you have a patient on a mood stabilizer, it's okay to use an antidepressant. And what that STEP-BD study showed was that the patients that were on monotherapy with a mood stabilizer and then had a antidepressant added didn't do any better. So there's really not a whole lot of evidence to support the use of adding an antidepressant. What they also saw in that studies was that those patients didn't cycle any faster if they were on an antidepressant or if they weren't. So the idea that, putting a patient on an antidepressant is going to make them change, make them flip to mania, that's not always true for everybody. So if you have a suspicion that the person has bipolar disorder, I'm not kind of giving this lecture to like scare you away from ever using an antidepressant, but you do have to let the patient know that, hey, you know, I have this idea, you know, or I'm concerned that maybe you have bipolar disorder. So why don't I talk to your family member? Why don't I talk to your wife or your husband and see if there's any more history that's suggestive? And then if you do start an antidepressant, say, hey, if you start to feel more depressed, more irritable, keyed up, stop the medication and give me a call and we'll start over. And so that could be a key in that the patient has bipolar disorder, or they just don't have a good response from SSRIs. What you wind up seeing is that there's a pretty large section of our patients that just don't respond well to antidepressants. They tell you they'll come in and they say, this made me more depressed, this made me more irritable. And we now kind of do more genetic testing with patients and find that, you know, there's people that are just poor responders, and that's separate from having bipolar disorder. So you can have a depressed patient who doesn't do well on an antidepressant. Any questions before we go to anxiety about doing this? The big thing is no monotherapy with antidepressants and making sure you get a good history with your patients before you do prescribe it for depression. So kind of jump into anxiety disorders. Can you guys see this graph? This is like really hideous. So this is from the WHO. And the only real key point down here is the U.S. prevalence of anxiety disorders, and then the U.S. prevalence of any disorder. So this is over a lifetime. 31% of patients will experience, or the prevalence is 31%, and then the expected lifetime prevalence is 36%. So, I mean, this is pretty common. Like, you know, 1/3 of folks will have experience symptoms of an anxiety disorder over their lifetime.
More than any other country.
Yep, yeah, that's the other thing. I know, and it's, you know, there's always the question of, you know, why is it lower in different countries? You know, I think part of it is that a lot of our illnesses, or especially psychiatric illnesses, are kind of bound by culture. And I think that's kind of important to take into effect, and to take into consideration. So just someone comes in and tells you they're anxious, it's important to remember that feeling anxiety is normal and that it's usually a good thing. If you're feeling anxious about an exam, it's because, you know, maybe you should be studying harder. Or if you're feeling anxious about preparing this lecture, it's maybe you should do it, you know, several weeks in advance. But, you know, so it's normal to have anxiety. So I think part of when folks come into your office and tell you they're feeling anxious about things that are going on in their life, I think it's really important to, you know, have empathy for the situations that they're in and to normalize it to some degree. Like, man, that sounds like what you're going through is really tough. Instead of just thinking, geez, okay, let's get this under control with an antidepressant or anti-anxiety. Because if somebody has, like, you know, their house burned down, they're going bankrupt, you know, they got all this stress going on, it's probably unlikely that giving them an antidepressant is going to do anything for their situation. And, you know, long before we were kind of dealing with anxiety as a psychiatric and a medical illness, you know, it was something that philosophers would talk about. So Kierkegaard talks about anxiety as predating sin. So the first choice, and you know, that Adam had in the Garden of Good and Evil was he going to eat this apple or was he going to listen to what God told him? So he had this anxiety about, geez, I don't know, I was told not to do this, but I have a choice. So having choice kind of creates anxiety. And when you look back at philosophical text about anxiety, what you find is that people are usually anxious because they're thinking about the past and they're thinking about the present, and they're not staying, or they're thinking about the past and they're thinking about the future, and they're not staying present. So philosophers would often talk about the way to beat anxiety was to stay in the moment. And I think that's important only because you should be thinking more about psychotherapy, cognitive behavioral therapy, kind of non-pharmacological treatments for anxiety before you jump to antidepressants. Because these old folks, these guys figured this out long ago that they didn't need antidepressants to make their anxiety better. So we'll kind of break down the 4 most common anxiety disorders you'll see in your clinic. Post-traumatic stress disorder, they've changed DSM-5, and so now PTSD is not kind of in the same, it's under this like trauma-related disorder category. But most of these studies talk about anxiety disorders using these four most common. And looking at MixApp, you guys use DSM-4 criteria, and it's not really any different between 4 and 5. So thinking about anxiety in terms of these four realms, I think will be the most helpful. General anxiety is pretty easy to pick out. So this is someone who is excessively worrying, usually about things that aren't super important, and that they have a hard time controlling their worry. And so they'll come in with neck pain, they're keyed up, they have a headache, they can't sleep, their mind's racing at night. Generalized anxiety is a pretty easy diagnosis to make, but a lot of times we wind up under-treating it, under-diagnosing it. And where it becomes a problem, normal anxiety is normal, but when it causes impairment in their life, that's when you really should think about options. Social anxiety, this is also straightforward, is that there's fear about specific social situations when you feel like you're going to be judged by others. So, me standing up here, feel like I'm going to get laughed at by my peers. That would be social anxiety. And then you work to avoid those situations. And then the fear is out of proportion to the event. So the example would be someone in a patient who you see in the clinic has this fear of going into the cafeteria at work because they're really afraid that they're going to drop their tray. And when they drop their tray, that everyone in the cafeteria is going to stand up and laugh at them. You guys have been in the cafeteria and you've probably seen people drop their trays, and usually people don't stand up and laugh at them. But these are the things that people with social anxiety disorder will tell you that they're fearful of. And this usually goes on for some time. So you're looking at 6 months or more. Panic disorder, you have panic attacks, which are quite common. What makes it panic disorder is that anticipatory fear between panic attacks. So just having a panic attack in itself is not reason to kind of diagnose someone with panic disorder. Panic attacks are normal. Panic attacks happen to, probably just about everyone over their lifetime. I'm sure there's a fair number of people in this room that have experienced a panic attack once in their life, and they're really unpleasant. But, it doesn't become a problem unless you have multiple and you're worrying about having one, between. And then finally, PTSD. And so this winds up being really common in primary care because, especially here in Louisville, we work with an urban population, so lower socioeconomic class, more likely to be. We live in Kentucky, so we have a high rates of childhood abuse, high prevalence of substance use. So, a lot of times these patients that have substance use or childhood abuse will be picked up on a charge, put in jail, further traumatized, and come back out. So PTSD is really common. And so what you see is at first you have to be exposed to a trauma. That kind of makes sense. And there are different ways for which you can be exposed. It's either, it could be a loved one, being shot, or a close death experience with a loved one. It doesn't have to be directly you as the person. There's also some new evidence that there's trauma related to being in a relationship and your significant other in a relationship, cheating on you, having an affair, that you can experience trauma kind of by the violation of trust in that relationship. So the one thing that I think is important about PTSD is don't just think about it in terms of, gosh, this person's life was threatened in this moment. If you kind of open it up and be more broad about how you think about it, you wind up seeing it much more commonly, and I think you can treat it better. So you get the intrusive symptoms, which are those, flashbacks, nightmares, and you get the avoidance component. And you get, they become more depressed, more anxious, and then you get the heightened arousal. So this is the patient who's more irritable, snapping at their loved ones, maybe engages in more reckless behavior, can't stand loud noises, and can't sleep. And so what you wind up seeing, and I have one of my long-term psychotherapy patients who I've seen for probably 110, 120 visits. And when I first saw him, and probably for the first year of seeing him weekly, I thought that he had bipolar disorder. He also had this history of childhood trauma, but he had a lot of affective instability. So he would come in, he'd be really keyed up and irritable. I'd have him go home and keep a log of his mood, and he would show this kind of clear pattern of being really keyed up and then periods where he'd be really depressed. And so I was like, this guy's got bipolar disorder, and started treatment, made sure he wasn't on any antidepressants. But as I continued to see him through treatment and really kind of worked on addressing the trauma issues, all the affective instability started to melt away. And it's been about 1.5 years, and I haven't seen like any depressive symptoms from him, and he feels like he's doing really well. And so when I saw him just a couple of weeks ago, we were talking about, I really don't think that you're bipolar, that I think that this was really, more symptoms of PTSD that were, presenting as this labile mood and irritability and recklessness. So that's only to kind of illustrate that these things are hard diagnoses to get at. And so taking time with making them, and then also kind of considering all the options. And so this was an article that ran in a journal of Annals of Internal Medicine. So they had just about 1,000 patients, and of these 1,000 patients in this clinic, almost 20% of them had reported an anxiety disorder. And what they found was that of those 4 anxiety disorders, so you have generalized anxiety, social anxiety, panic, and PTSD, is that across the board, the folks that have anxiety experienced worse functioning, more disability days, and they were greater utilizers of healthcare. And of those patients that had anxiety, 2 out of 5 of them were not on any sort of treatment at all. And we have really good treatment options for anxiety disorders. And we also know that psychotherapy is less expensive and more effective than pharmacotherapy for these patients. And now there's lots of growing evidence supporting the use of internet-based cognitive behavioral therapy. So it's not so much that you even have to, have them go see a therapist every week. But if you can get them to buy into the idea that, hey, we can treat this, but it's not going to be with a pill, then these patients can do really well. And go ahead. So it kind of depends on what type of insurance cover they have. So most insurance companies will pay for psychotherapy. And some of them are really good plans. Like if you have the PPO at U of L, it pays for an unlimited number of psychotherapy visits, and the copay is $15. So there's really good options. A lot of times it's hard to find a provider. And so if you can't find a provider, what you can do is start to look for these internet-based options, or even some of these workbooks. I mean, a lot of the psychotherapists, what they'll do with the patients is kind of take a workbook approach to cognitive behavioral therapy. So making some recommendations on, there's one common one called the Feeling Good Handbook that you can get a used copy on Amazon for like 3 cents plus $1.99 shipping. But there are good options for treating anxiety. Also things like exercise and yoga and mindfulness. There are other options.
Remember, if your patient works for a decent corporation, Kroger, UPS, something like that, you can utilize the employee assistance program that virtually all of these companies have, and you get 6 free sessions of counseling or therapy that you can utilize, which gets people on the way and helps them to decide that they want to continue that. Yeah.
And a lot of times, going to therapy for anxiety is not like laying on a couch and talking about the horrible things that happened to you as a kid. You usually it's 6 to 12 to sometimes 18 visits, and then you see a great reduction in symptoms, and then the person continues to do well. So this is kind of like the idea that you're teaching them, how to cope better, how to manage their anxiety, and then you give them those skills, and they kind of go off running. The last part is that, as part of the preventative task force guidelines, is that you should be screening all your patients for depression and anxiety, and these screening tools work well. So the PHQ-2 is asking, have you ever experienced depression? And then have you been feeling like any suicidal or hopeless thoughts? The GAD-2 is asking about excessive worry, and then I can't remember what the others. Excessive worry and not being able to control it. And so those are pretty easy things that you can, have set up at your clinic at the front desk. Every patient comes in, it takes a second to to fill these out. And then so, based on their score, you either ask them more questions, you give them a full screener, or you try to refer them to a mental health provider. And so the nice thing about anxiety is that kind of across the board, medication options are straightforward. So you're thinking about SSRIs and SNRIs as first-line treatment. And you can also think about buspirone, Buspar. Buspar has a pretty long onset of action. It usually takes 4 to 6 weeks, sometimes a bit longer. So it's not a whole lot. It's not like you give it to them and it's going to work right then. The treatment for social anxiety, panic, PTSD, generalized anxiety, they're all using SSRIs, SNRIs. And looking over at the MixApp questions, that was pretty straightforward, is that you look at the list, this person has an anxiety disorder, and you pick an antidepressant. The big thing is that you really want to avoid benzodiazepines. Driving over here today, there was on Diane Rehm show today, they were talking about the opioid crisis. And then one of the callers had called in talking about, how they got started on Xanax and it led to opioids. And what you're seeing is that in psychiatric clinics in town and in other places that psychiatrists are really starting to reduce the volume of benzos prescribed. And so what is happening is those folks are showing up at their primary care clinic asking for refills. And so these patients who we've done a disservice to by kind of starting on these medications are looking for other places to get them. And the most likely place for them to go is going to be to primary care. So I'm not saying that because you shouldn't let them into your practice, but if you're going to be having patients that are on long-term benzodiazepine use, you should really be starting a conversation with them about reducing their benzodiazepine use, switching to other agents. They're not going to like it. It's going to be the same thing you face with trying to reduce opioid use in patients, but it's really in their best interest. And I really think that, on the horizon, what we see now with opioids, we're going to see with benzodiazepines. They are efficacious in the short term. This is where the problem is that they actually work really well, but they work great, and then you can, develop tolerance to them, independence to them, and then your anxiety continues to increase. And so you're faced with the same situation you are with opioids, that you have to continue to increase the dose with no improvement in symptoms. So if you are going to use a benzodiazepine in your patient, the instance would be like you have someone who gets really nervous about flying and they fly a couple times a year. So you give them a small prescription of Xanax or Klonopin. You'd prefer to use the longer acting agents, and they use it just before they get on the plane. Or if you do have someone that you're starting the antidepressant, but you're worried about them becoming kind of more keyed up when you start the antidepressant, you can use a benzodiazepine as a short-term kind of like fill the gap. So you say, hey, I'm only going to prescribe these for 2-3 weeks while we kind of get this SSRI into your system, and then after that, we're no longer going to prescribe it. So I think it's important to have those conversations at the onset that, hey, I'm going to write this, but this is not going to be a maintenance medication. Any questions about that? I think that's kind of a big takeaway. I just had a patient in my clinic who I've been tapering her on benzos. She has been in psychotherapy, and she came in and said that she didn't need to see me anymore because her primary care doctor said that he would fill the benzodiazepines at the dose that she used to be on. And so she thanked me for my time and left. And so, what I did immediately was I called that physician and left a message and said that, hey, you can kind of do what you want to do, but I want to let you know that this is the direction that I was heading with this patient, and this is why I was doing it. So I'm hoping that my peers will be calling primary care more in the future and kind of letting them know, because I think that you guys, if you haven't already, you're going to see more people show up at your doorsteps asking for these medications to be refilled. And then the other medication that you'll see in anxiety disorders is prazosin. And what you wind up seeing it used is primarily for nightmares, treating nightmares. Alpha blockade, they found out that it not only helps blood pressure, it helps with nightmares, particularly in PTSD. The study had wildly varying doses, so usually it started at 1 or 2 milligrams, but it was tolerated up to 16 milligrams. Now, I've never seen a patient on 16 milligrams of prazosin, but in our psychiatric clinic, a lot of times we'll see 2 milligrams in the morning, 2 milligrams at noon, and then 4 or 6 at bedtime, which is a pretty hefty dose and without any cardiovascular effects. So prazosin is a really good option, especially for folks that are fairly asymptomatic from PTSD but have these really intrusive nightmares. Starting at 1 or 2 milligrams at prazosin can be really helpful. And then, of course, you can use a beta blocker for performance anxiety. So one more question for anxiety disorders. It's a 28-year-old female, comes to the clinic, chest pain. She has heart palpitations, numbness, feeling nauseous, and then has a sense of doom at times. She had a normal lipid panel at her last checkup, no family cardiac history, and a normal EKG. Doesn't take any medications. These episodes are embarrassing, and she finds herself worrying about them at work. So what should our initial treatment be? What do we want to do? A. Yes. So this was almost identical to one of the mix-app questions, and they have the little breakdown of who answered what. And it was actually a really close tie between having the patient wear a cardiac monitor and prescribing an SSRI. And I can't remember if more people picked cardiac monitor SSRI, but the correct answer is SSRI. And the reason it's correct is that she's an otherwise healthy patient with no cardiac history. So if you have a healthy patient without a cardiac history, you really should be thinking about anxiety before doing a big cardiac workup. Now, if they have a family history, or if they have, other symptoms that may be suggestive of cardiac problems, you might want to have them wear a monitor. I know this is, if I'm trying to put myself in the shoes of a primary care physician, I think it would be hard for me not to work it up, but that's what MixApp told us to do. So that's what I'm going with.
I can tell you, being married to an EP doctor, he's diagnosed 3 WPWs in the last 10 years, and they all had like this. Yeah. Oftentimes they don't have cardiac histories because they're young and this is the first time. Yeah. So I would have had a hard time picking a day, but just because of my history.
But they have EKG.
They did. Well, I can't tell you on 2 of them they did. Oftentimes they don't have it delta. Now the one I don't know for sure, but yeah.
Yeah, so I think especially for cases like that, if it continues to persist despite having a treatment with an SSRI, or maybe sending them to psychotherapy and it continuing to persist, then you want to think more about cardiac workup. But yeah, no, I think that would be a hard thing to sell. But without any history, that's what MixApp wanted us to do.
It'd be interesting to see what shows in the between your own male.
Yeah, actually the question, I changed the question. So the question was a male, and it was still the split. Now, me making it female, I added the normal EKG to kind of soothe the idea that this could be atypical chest pain. So I probably made it a little more ambiguous, but I hoped that the normal EKG would clear that up. But the question asked about a male. So in a male, certainly, thinking about this as primarily anxiety. Dr. Campbell, you got a question?
Yeah, being a former cardiac surgeon, I have put in there that you want to listen to make sure this patient doesn't have a murmur of mitral valve prolapse, especially in a female, Barlow syndrome that's called, because they are very prone to panic attacks, anxiety, and generally a beta blocker for their mitral valve prolapse will take care of it.
Cool.
That question was on my notes before 30 times through. That exact question.
So the final one is somatization disorders. We're good with time? Yeah. So this the citation got cut off. But of the 14 common symptoms seen in ambulatory practice over a 3-year period, only 16% the physician was able to find an organic etiology, which I thought was pretty surprising. Maybe to you guys it's not. And the 14 disorders that they counted was chest pain, fatigue, dizziness, headache, edema, back pain, dyspnea, insomnia, abdominal pain, numbness, impotence, weight loss, cough, and constipation. So of all those chief complaints, only 16% of the time were they able to figure out that there was an actual organic cause. They did diagnostic testing in about 2/3 of those patients to come up with the 16%, and only about 55% of them got better with treatment. So there was some percentage of patients that just got better by coming back or just seeing your pretty face, or didn't follow up again. But the only reason I bring this up is to talk about how difficult it is when people come in with these vague somatic complaints and this idea of okay, what do I do? So we know that somatic symptoms make psychiatric illnesses worse. This U.S. National Household Survey, they had 1,500 patients with depression, and those patients that had depression and described having aches and pains reported more psychiatric distress and a worse physical and mental health status. This kind of makes sense. Those patients with pain were more likely to come to the primary care office. They're coming, 20% more, and they're also less likely to see a psychiatrist. And then having aches and pains, having somatic complaints in conjunction with your depression or anxiety makes those episodes last longer. And then a lot of times, your patients are not going to come in and tell you that they're feeling really, they're really depressed or they're really anxious. They're going to talk primarily about their somatic complaints. So this is either because the culture that they come from, there's still stigma against mental health. You see it a lot of time in imprisoned patients. So patients who have been are currently imprisoned or were imprisoned, they'll come in and they'll rattle off this long list of somatic complaints when probably underlying what's going on is a psychiatric illness. So this is I thought this was pretty interesting to see, because I think as a psychiatrist, a lot of times I have patients that come in that talk about how bad their pain is, and I kind of think, phew, I'm so glad I don't have to treat their pain. When I'm kind of doing the same thing, that I think primary care is probably doing. Gosh, I'm glad I can just treat the pain and don't have to worry about the depression. But what I realize is that I'm really doing a disservice, and that them reporting pain, should be a real clue into me that maybe their psychiatric illness is not getting better, and maybe my treatment should really focus on improving their pain as a way of improving their psychiatric illness. So DSM-5 changed how we categorize somatic disorders. For MICSAP, they used DSM-4, and so how the questions were set up was that you'd have a patient that had a bunch of physical somatic complaints that began before the age of 30. And so usually the question said, this person was 33 and had these problems for several years. And the symptoms were in multiple organ systems, and they would come and go. They wouldn't all necessarily have to be there at the same time, but there wasn't an explainable way to link all these symptoms together. So what DSM-5 did was kind of took all the different somatic disorders and then put them under one big heading, and they now call it somatic symptom disorder. The big difference being that you only really need one somatic symptom to meet criteria for this. So you don't have to really worry about, the person that has GI distress that also has, a headache and, shortness of breath. Just having one symptom is enough. And the reason that they changed it, or the reason that the APA said they changed it, was that they wanted to try to focus more on the distress and focus less on trying to rule out all the possible things this could be. So focusing more on the positive symptom and less of like proving the negative. So looking up somatic disorders, what I came across is this new way of talking about them, and they call it bodily distress syndrome. And bodily distress syndrome is kind of the new, have you guys heard it? Okay. It's the new way of talking about medically unexplained symptoms. So this is like the new, fibromyalgia, irritable bowel disease, functional syndrome. So what they did, and this is going to be rolled out for ICD-11, is that all these functional disorders are going to be grouped likely under this bodily distress syndrome headline. And it's not like earth-shattering. The diagnosis of bodily distress syndrome just requires greater than 3 symptoms from cardiopulmonary or autonomic arousal, GI arousal, musculoskeletal tension, or general symptoms. So, it's really vague. So, of course, you're going to have it as an umbrella term. But when I was looking at the literature for bodily distress syndrome, what popped up for me was it sounded like another way to talk about difficult patients or to group the patients that really frustrate us in our clinics. So it seemed like the new key word for, they're just a frequent flyer, or it's functional, or it's conversion, it's psychogenic, kind of whatever. So it wouldn't surprise me if the way that we start talking about these people is with using bodily distress syndrome, which I think really does them a disservice, because patients that experience the somatic syndrome or this new bodily distress syndrome, we also have to remember that they're not doing this for them. They're not doing this because they really are enjoying it. There is a subsection of patients that enjoy being, fulfilling the sick role or have secondary gain, but usually somatic complaints, they're not, that's not their primary goal. They're not feeling well. They don't know how to describe it. They don't have an explanation for what's going on, and they want your help. So grouping these patients and thinking about them in terms of a headache, I think, does them a disservice. And I think it also just kind of makes us become callous and hard. So I think it's kind of always important to remember that our patients are suffering, and to not be tricked by these new fancy terms, because I think this is going to be the next difficult patient, is our bodily distress syndrome patients. We're going to see that as a chief complaint. So I think that does it. Any questions to wrap up or about treatment stuff?
One of the things I see when I do consult, I've seen, is that if you don't have a psychiatric history, you have every test known to man run. And if you do have a psychiatric history, or you're difficult, they immediately jump to a psychiatric diagnosis and they miss a lot of stuff, which is how I picked up a case of Lyme disease as a psychiatric consultant, because we never checked serologic markers for someone who was from Connecticut and was a hiker. So,
yeah, no, I think it's really, it's easy to talk about psychiatric patients and immediately assign whatever symptoms they have to their psychiatric illness. I had the patient that actually developed Stevens-Johnson syndrome. She was a nurse and had these episodes where she would not sleep well and then kind of become really bizarre and show up at the hospital. And she had this starting when she was about 18 and had maybe 10 or 12 hospitalizations. And I saw her after she had been admitted, and she had gotten a dose of an antipsychotic and a dose of Ativan, pretty common combination, before coming up to the unit. And when I saw her, she looked pretty, it was a little groggy, but almost completely normal. And she had been labeled as having a bipolar disorder and schizophrenia. So I started seeing her in the outpatient clinic, and I ordered an EEG on her because I thought it was really strange that this lady recovered so quickly from just a single dose of an antipsychotic and a benzo. and I worked with her. She, changed her night schedule so she wasn't working evenings. But she went to one of the neurologists in town after a shift to get an EEG, a sleep-deprived EEG. And sure enough, she had temporal lobe epilepsy. And so what was happening was that she was seizing but would present really confused. And it was just the dose of Ativan that, fixed her. So, and I was, looking back over her charts, and all these psychiatrists had labeled her as, non-compliant with treatment because she would stop taking the medicine, or belligerent, and she, wasn't accepting. And here was this young lady who, really just had, a seizure disorder, and that had been missed by psychiatrists for a long time because of that presentation. So it was eye-opening to me, and I always remember it because I would hate to do that again, because having these labels, if you don't have it's a big burden. So kind of always keep your eyes open to being open to different disease processes. Any final questions or comments?
Hey, Zach, what would you say? I remember when I was a medicine resident and our psychiatrist came in and gave a lecture, and he, at the end of the lecture, he talked about physician burnout, troubles that physicians have with depression and anxiety, and also sometimes, bipolar and all those things. And during the era when I was a medicine resident, he encouraged us, if we felt like we needed psychiatric treatment or psychotherapy, he said, make sure you pay for it out of pocket, you don't want it on the record. How do you feel like things have changed? And what would you tell a physician who wanted to seek out mental health services now? Yeah, so, and so it's always, I think it's always a little bit different as a psychiatrist, because I don't worry about it. I know, and the reason I know about how U of L's insurance pays is because, as part of psychiatric training, it's really helpful to go see a psychotherapist. So, I go see a psychotherapist every week for an hour, and I'm lucky that my department gives me protected time to go do it. And I pay a $15 copay. He bills my U of L insurance, and it's really been wonderful. Yeah, I'm disappointed that he's on vacation because I can't go this week. But so I don't think, if I had a peer that wanted to see a psychiatrist, if they felt uncomfortable coming into the clinic, certainly where they might be running into some of their patients, we could work as, have them see someone else in the community, or certainly make some, if they wanted to come into the clinic, maybe make some adjustments in, what entrance they used. But I don't think it's the big mark that it used to be. And I certainly wouldn't think any less of one of my peers. It actually would be nice if I could have conversations of the enjoyment of psychotherapy with some of my internal medicine peers, because it's really been helpful, just in terms of how I think about patient care, to have the experience of kind of being on the other side, at the very least, I think is helpful. Dr. Campbell, do you have any thoughts on?
The other thing to think about, too, is when residents are experiencing problems is substance abuse. The incidence of substance abuse in house staff is higher than it is in the general population. The incidence of suicide is also higher, especially in interns. In fact, the incidence in the first 6 months of suicide in interns is almost 30 times the national. Don't be afraid to come forward.
Yeah. I think Drew and I went to many cadaver ball parties where you kind of thought, geez, my medical student peers drink a whole lot, and we kind of we look for ways to deal with stress, and so I'm glad that university is doing mindfulness classes, and I really hope that they start more actually in the hospital, and I hope that the ACGME makes resiliency and makes burnout prevention a milestone, because I think that's really the only way that it's going to improve, is that if we actually make it part of training and make it so that you actually get time to do the things, practice those things. So.
Well, and I know too that GLMS, I think of which all of us in here are probably members, they also have counseling, free counseling services through a private, I think, psychology group.
Yeah.
Lagrange something.
Yeah, and that's new this year too, I think.
Yeah, it is. So,
Yeah. If people haven't been, I really encourage you to go for a couple sessions, because I mean, even if you don't have to have like a great, you don't have to have something, you don't have to have a diagnosis going on to go and talk to somebody. It's really, really helpful. I mean, I don't think I had a diagnosis going in, and I've been going for weekly for a year, and it's been so helpful in just thinking about, how I approach problems and how I address, things in my own life and things with patients. It's been immensely helpful. So I encourage everybody, if they have an opportunity to do it, because as a resident, it's probably the easiest time to do it. And if you make a case, I would be willing, maybe your program director or folks would be willing to help, give a little protected time. I don't know, maybe it's wishful thinking, but if you don't ask, you're not going to get it. I see some smirks.
It also varies from department to department. I mean, I've never had a surgery resident come see me because, when I was a surgery resident, even eating was considered a sign of weakness.
Yeah.
So, certainly saying, hey, I'm depressed and anxious, or I have bipolar disorder to your chairman, sometimes is a little difficult.
Yeah. Well, thank you guys. I appreciate it.